Very happy to welcome all of you to this afternoon's presentation on cultural safety, implications for addressing maternal mortality morbidity among Indigenous women. And we have a great team from the Division of Community Behavioral Health presenting today. Dr. Yellowhair is Dine Navajo and is currently a psychologist and assistant professor in our department in the Division of Community Behavioral Health. Dr. Yellowhair is also the current chair for the Division Inclusion, Diversity, Equity, and Accessibility Committee, and the project director for the SAMHSA-funded Trauma Informed to Build Resilient Indigenous Balanced Communities Enhanced with Strength project that focuses on raising the standard of care and improving accesses to services for traumatized children, their families, and communities throughout the United States. Dr. Jennifer Crawford is also an assistant professor and a psychologist in our division, and she serves as the Director of Clinical Services and Research for Reproductive and Perinatal Mental Health. Her clinical and research work focuses on increasing equitable access to behavioral health services within women's specialty care settings, especially perinatal and mental health settings. And she also serves as the clinical director of the Journeys Perinatal Mental Health Program at UNM. Jennifer Nanez currently serves as a lecturer too within our division, and she is an enrolled tribal member of the Pueblo of Acoma and is a daughter, sister, and auntie and mother to two young Indigenous matriarchs in training. She has been in the social work and education fields for nearly 30 years, with experience working across tribal, urban Indian, federal, and university systems, with an emphasis in serving the American Indian population. Her interests lie in suicide prevention and mental health treatment and support, and her work promotes effective community engagement and clinical practice, emphasizing cultural resilience, connection traditions, and Indigenous-based knowledge and healing. And Teresa Gomez is an enrolled member of the Pueblo of Isleta and a lifelong resident of New Mexico. She is also a lecturer too within our division in our department. And her career has been dedicated to serving tribes and advocating for issues affecting American Indians. Ms. Gomez served as the Deputy Cabinet Secretary for the New Mexico Indian Affairs Department and also as the Deputy CEO for the New Mexico Behavioral Health Purchasing Collaborative. She's worked extensively with tribal governments and government agencies at the federal, state, and local level, and has been instrumental in building and strengthening tribal-state relationships and collaborations. So welcome to all of you, and we look forward to your presentation.
Hello, everybody. I think that you can see our slides, right? Great. Thank you, Dr. Bonham, for that lovely introduction, and a shout out to the team here. We brought this presentation together originally for the 8th International Meeting on Indigenous Women's Health that's held every few years here in Albuquerque, New Mexico. It's hosted by the American College of Obstetrician, or OB-GYNs. And we had a really great time presenting this talk there and visiting with and learning from folks from across North America. So this is a really beautiful piece of artwork that was commissioned to sort of highlight the work of that meeting. So I'm just sharing that here with you as well. All right, real quickly, our objectives are to, hopefully you'll leave here understanding more about the recent impact of maternal morbidity and mortality on Indigenous women and communities, be able to explain cultural safety, its principles, and how it may inform healthcare innovations and practices to decrease maternal morbidity and mortality among Indigenous women, and describe the implications of cultural safety of that model on women's specialty care, including OB-GYN settings. I know that we are not presenting to a room full of women's health providers today, but I do hope that this may spark a lot of questions that you have, and hopefully we'll have some time at the end to answer those as well. We don't have any conflicts to disclose. And just to get us started, I'd like you all to be keeping a case in mind. This is a composite case. A new mother drove 3 hours today for her 8-week postpartum visit. She's attending with her infant. She gave birth to her daughter at 35 weeks after presenting with high blood pressure at a routine visit. She was able to stay with family during parts of the NICU stay and was relieved that her child came home within 7 days. At today's visit, the patient reports that she was recently taken by ambulance to a hospital closer to her home before transferring to a larger hospital and being admitted for several days. She explains that she thought her headache and belly pain must be normal and that she tried to ignore them because she had been so excited to have the baby back home and was focused on caring for her. When she started vomiting and having blurry vision, her sister called for help. When the provider came into the room to see the patient, they asked, "Why didn't you go to the hospital sooner? You could have died." So I'm going to try not to get too caught up and spend too much time on some statistics, but I do want to highlight a few things because I think it helps us understand why understanding historical trauma and cultural safety is so important. So I'm sure we all know that the US has alarming rates of maternal mortality. It's increasing over time, and compared to the rest of the world, quite alarming. And addressing racial and ethnic disparities in those maternal mortality rates is essential. In a large report that covered 36 maternal mortality review committees in 36 states in the US, with a sample of over just about 1,000 deaths, a little bit over that, between 2017 and 2019, they found that mental health conditions was one of the top contributors to pregnancy-related death. If you want to know specifics, it was 23% of the deaths, but mental health was in the top position overall. In New Mexico, it rises to 36% for pregnancy-related deaths, and closer to 40% if you include all pregnancy-associated deaths. Now, in this national group, hemorrhage, cardiac, and coronary conditions and infection, of course, followed mental health, and some of these things varied by race and ethnicity. The data in this very important report, which has spurred, if you've been watching, for example, research funding, has spurred a lot of movement and momentum on increasing research funding in women's health. However, within that report, the data on Indigenous populations was reported as non-Hispanic, single race, American Indian, Alaska Native, and non-Hispanic, single race, Native Hawaiian, Pacific Islander, and the samples were really small. In a follow-up report, the same research group expanded and broadened that definition, and they increased their sample just a little bit. But I think it's important to notice that often these groups are underrepresented in the data, even when we think we may be capturing good data, that something may still be missing. In larger studies and reviews of maternal mortality in this population, the adjusted risk ratio is just under 2 times higher risk of pregnancy-related death among American Indian, Alaska Native individuals compared to non-Hispanic white individuals. When you look at the data from more of a pure mortality surveillance kind of level rather than review committees, which are being standardized and are provided a lot of support by the CDC to do that, the broader data does seem to kind of catch some of these disparities more reliably. And you can see that here with non-Hispanic, Native Hawaiian, or Pacific Islanders showing the highest level of pregnancy-related deaths, followed by non-Hispanic Black and non-Hispanic American Indian or Alaska Native individuals. Again, not surprising to most of us here, suicide and overdose deaths are one of the large contributors to that maternal mortality and are likely underreported. They also are preventable, and you see that in both the national and New Mexico maternity, the review committee data. 80% are considered preventable. Nearly all of the mental health and substance use deaths are considered preventable. PMADs, perinatal mood and anxiety disorders, you may most commonly think of that as postpartum depression, but it's much more broad than that, is estimated to impact 15 to 20% of pregnant and postpartum people in the US. However, among American Indian, Alaska Native women, there's good evidence that that number is likely much higher, with research ranging from 14 to about 30%. And that variation likely represents differences across sampled groups. Okay, so when we look at research looking at maternal mortality, a recent review of maternal health for American Indian and Alaska Native folks found that very few studies look at things beyond individual factors. So they look at social or SES, they look at cultural beliefs, behavioral risk factors like smoking, but very few examine things like transportation infrastructure, insurance coverage, family welfare systems, the availability of prenatal care and how easy it is to access, racism and discrimination, things like that. A quick note about insurance coverage. In the national data, women who are Medicaid insured are 5 times more likely to die from a pregnancy-related death. So just as an example of the role of how understanding the historical context is so important for understanding how to change maternal mortality, especially with this population. There's this really great Maxwell and Thomas study from last year that looked at historical land allotment and the impact it has on transportation access, and in turn, the impact it has on decreasing prenatal care and access. Additionally, across 37 pieces of federal legislation recently introduced that address maternal mortality, only 6 drew attention to health inequities and social determinants of health. Only 1 highlighted historical trauma and discrimination related to maternal death among American Indian individuals and Native Hawaiian women. So it's really important to understand the historical context and the role of historical trauma when trying to address maternal mortality for Indigenous women. And with that, I'll turn it over to Dr. Yellowhair to tell you more about historical trauma. Thank you.
Yeah, it on Scotia, DJ Yellowhair, Unishiak, Ashtin, Ishlosh, Bashishin, 1200 Dashin, Greetings, everyone. We're going to talk a little bit about historical trauma and how it impacts women's health. But in order to understand historical trauma and why trauma-informed care is so important from a historical trauma perspective in New Mexico, I want to highlight a few things about his history and healthcare and why it has created this trauma response in American Indians, especially American Indian women. Now, we could go through several hundred years of history point by point, and I could point out all the policy, legislation, and everything that has led us up to today. However, I won't do that. We're going to there's a few bullet points that I do want to take you through and about American Indian healthcare history. Back in 1868, the Fort Laramie Treaty promised to provide healthcare to American Indians. So healthcare has been something that has been promised through treaties, through policy, through legislation, but not always carried out or delivered with quality to American Indian populations. Later on in 1879, the first students arrived at Carlisle Industrial School in Pennsylvania. Healthcare was then transferred to the responsibility of those residential schools. Later on in 1954, so we think about history. When we think about history, we often think about history of things that happened a long time ago, but this is really recent. 1954, when Dwight Eisenhower signed the Indian Healthcare Transfer Act, establishing the Indian Health Service, that wasn't that long ago. So you want to go ahead to the next slide? Some of these dates are a little more recent. And what I want to point to here on this slide is in 1976, the U.S. Attorney General's office found that 3,406 American Indian women were sterilized without their permission between 1973 and 1976. So there have been atrocities that were perpetuated on American Indian women and American Indians through healthcare systems throughout history. What's important to take from this is that policy, legislation, and things like that were not created to benefit American Indians across time were utilized in a way that that perpetuated trauma. If you want to go to the next slide. So all of that history and all of the policy and legislation that wasn't created by American Indians for their benefit created what we call historical trauma. We're so lucky to have Dr. Braveheart at the University of New Mexico who coined the term historical trauma. It's the cumulative emotional and psychological wounding from massive group trauma across generations, including the lifespan. She created this model, and we'll go over it a little more in a few more slides, but the historical trauma and unresolved grief model really spoke to how policy legislation impacted and created trauma for large groups of people. One key thing about historical trauma that is often forgotten is that it includes the lifespan. So everything that happened throughout history up to a minute ago is included in that lifespan. So when we talk about historical trauma and its impact on healthcare and how American Indian women and American Indians perceive healthcare systems, all of that is intergenerational because of things that started back in the 1800s. Those policies and legislations that were passed back then impacted the way those women saw healthcare systems. And then they taught their children that those healthcare systems were not created for them for their benefit. And it got passed down throughout the generations up until today, everything up to a minute ago. Go ahead and next slide. In this, with what gets passed down is what we call historical trauma response. It's a constellation of features that is a reaction to that massive group trauma. And it shows up differently for everyone, but often looks like some of these things: survivor guilt, depression, PTSD symptoms, can come up looking like hypervigilance, psychic numbing, fixation to the trauma, can come up in somatic symptoms or self-destructive behaviors, compensatory fantasies, a death identity or fantasies of reunification with a deceased or feeling like they cheated death. That often ties to their fixation to trauma or other things, preoccupation with trauma or preoccupation with death, feeling a sense of loyalty to the deceased, internalization of ancestral suffering, the feeling that vitality of one's own life is a betrayal to the suffering of ancestors, and trauma responses. These trauma responses are always activated. So it's really important to, one of the things that's really important about understanding how historical trauma response feature shows up is that historical trauma was not created to pathologize the way that symptoms show up, but really help us get an understanding of why these responses are happening and how historical trauma has impacted patients or families and oftentimes whole communities. Next slide. There are studies that link historical trauma to epigenetic change and how it impacts children in utero or children in their development. So a lot of it leads back to the lack of access to social determinants of health. So individuals and families' socioeconomic status, racism, discrimination, bias, and historical loss. So if we think of that, if we think of some of the ways that that healthcare systems have impacted mothers, it's important to think about how they then transmitted that to their children. So there are two pathways that were hypothesized by Conchin and Thayer in 2019. We have them listed here, and the resources for this are also in our resource list at the end of the presentation. But there was, that's fine. Go ahead, Jennifer. So when we, I made a point to really hit home on the policy and legislation and how the outcome of that really shifted birthing practices to that birthing practices that were cultural and traditional and seeped in traditional practices and stories and legacies of matriarchal systems were shifted to be more Western-based, hospital-based. And if we think about a hospital setting, oftentimes when we hear someone's going to the hospital, the immediate response isn't always, oh, there's something joyous happening, like a childbirth. Hospitals are often associated with something negative happening or some end of life. And in many cultures, there's that transition of something negative happening with something joyous or something very traditional and sacred, like a birth. Those two sacred practices happening at once in the same space can be taboo for many cultures. The non-consensual sterilizations that occurred in the Indian health service system had a huge impact for generations. And it also impacts the way that women seek birth control services or seek out family planning. So westernized medicine often doesn't hold the same views of a woman's body or women and their place in traditional and cultural perspectives. So, you know, and it deters from the sacredness or the traditional practices of either bringing life into the world or life leaving from this physical world to the spiritual world. But most importantly, one thing that we really want to bring up, when we talk about historical trauma, like I said, we often think about things that happened a long time ago. Well, during the COVID-19 pandemic, Indigenous mothers were identified by zip code, and based on zip code were profiled, and their birthing practices were interrupted, meaning there was a hospital who identified women who were from zip codes that were often associated with tribal communities, and those women had their babies taken. And that was a policy that really had a detrimental impact on American Indian women who were going through the process of giving birth to their children and postpartum impact. Go ahead to the next slide. The reason we bring up the historical trauma model is because it is a strength-based model that we often utilize to understand trauma and how we transcend the impact of trauma to return to a more holistic and balanced space. So when we ask individuals to think about trauma-informed care from a historical trauma perspective, we're asking you to confront the trauma, be able to help patients embrace the history, understand it, help them release the pain, transcend the trauma so that they can have this holistic, balanced perspective of their mind, body, and spirit. Next slide. I'll go ahead and turn it over to my colleague, Jennifer.
Hi everyone, ang kuwazi kay tawa haupa, ang tishaname aza yakuku chinishanushita. So today in our session, we're bringing to you this concept of cultural safety, but we often hear of the culture of safety in working in healthcare. We want to differentiate the two. Now, the culture of safety in healthcare is based on the Institute for Healthcare Improvement's work in building in quality into our healthcare services. So examining again those processes and day-to-day procedures of how we deliver healthcare and how we are creating safety within the healthcare space. The original white paper that was developed to again create the framework for the culture of safety in healthcare focuses on 6 items, so focusing on what goes right in a learning environment and what goes wrong. Moving to greater proactivity, creating systems from learning, being humble, building trust and transparency, again, creating that just culture within our systems, and co-producing safety with patients and families. Those first 5 areas in the culture of safety and inequality in healthcare services is often what we hear the primary focus on. But we forget that 6th point, that recognizing that safety is more than the absence of physical harm. It's also the pursuit of dignity and equity. And this is where this concept of cultural safety can really begin to fit in to the work that we do in healthcare settings, both in behavioral health and in primary care settings overall. Next slide. So let's first talk about culture. And again, those keywords that we've heard over time in all of the work we've done across years and generations in working to address culturally different communities that we may be working with in our services. So those first kind of concepts that have come along include cultural awareness, the buzzwords around cultural sensitivity. And for a long time, we stayed within cultural competence as the primary phrase or term to consider in how we provide a culturally appropriate care, responsive care to patients and to clients. But more recently, we've seen this shift into cultural humility, which again is a wonderful term. And it really incorporates not only that lifelong commitment of learning about other cultures, but learning about ourselves and our relationship in the world. What are those intersectionalities that we may bring in terms of power, position, and place, and in the population then that we're serving, and how do those intersect? But it's still very much an individual one-on-one process. Cultural safety, which is our next step up the ladder here in the concept we're bringing to you now, really looks at it from a systemic view overall, looking at systems of healthcare, including policy, procedure, interactions, not only on the individual basis, but those systems as a whole. And it examines those histories that we've talked about, those histories potentially of trauma. So next slide. So this particular concept was brought up by Dr. Irapati Ramsden, who is a Maori nurse researcher. And this is in part why this particular concept has really resonated with us and with our team, in part because it is an Indigenous created model from an Indigenous worldview. And Ramsden wrote about her population, the Maori people, that at that time working within healthcare systems, that their view was not a perspective on the reality of anyone else. She was asserting that Maori people had their own whole, viable, legitimate reality, and insisting that their view and their experience was not a perspective, but a reality. So she, in questioning the healthcare services that Maori people experience, wrote that this leads to the question of choices in service delivery. The data on Maori mortality and morbidity and empirical experience has made it quite clear the health service is not and has not ever been culturally safe for Maori people. The service has not been designed to fit the people. The people have been required to fit the service. And we actually, again, resonate with that in our Indigenous communities, in part because while these systems provide us healthcare, provide us services, they've never been created from our perspective and from our worldview. And I will argue the same for other populations of color in particular. So next slide. So let's take a look at this definition. Cultural safety is defined as an outcome based on respectful engagement and recognizes and strives to address those power imbalances that we may have within our systems, in the system overall. But safety, in the key portion here, is it's defined by those who are receiving care, who our patient population is, who we are providing and again giving service to. And again, in serving in service to, I think, is another way that we should be thinking about this. Cultural safety encompasses cultural humility, but considers those timelines, those trauma histories, inequities, those social determinants of health, and really works to take on an active social justice and health justice stance. It's inherently anti-racist in its basis overall, and it serves as the constructs that impact health outcomes overall and works to transfer power from the system to the patient, that the patient is empowered in these spaces, and that we're working to create systems that support safety and equity. So next slide. So when we think about our public healthcare systems overall, this is an example, just as one way to think about this. Oftentimes in healthcare, we're focusing on those individual risk factors, that disease and injury burden potentially, and that potential for mortality. But they're often based in those individual constructs. What we're focusing on those skills, knowledge, and attitudes of the patient themselves. But we really do need to look at this next section here too, which is also those upstream measures. What is happening with social inequity? What are the institutional inequities that may be at play? And what are the living conditions, the environment that our population is coming from, is enduring, what's happening for them? Issues like transportations, in issues like environmental toxins in environments that we see. All of those things have impacts on our communities, including those histories of violence. Next slide. Now, when we've been talking about this within healthcare, and again, more recently, and once again, in truth, we're seeing again that push for trauma-informed care. Trauma-informed care systems and the way we approach care in our communities, care in our service systems, care in our hospitals should be based in this trauma-informed approach, looking at issues of trustworthiness and transparency, engaging peer support, empowerment and choice, looking at collaboration and mutuality, establishing safety, and of course, looking at those historic and gender issues that we need to encompass in our care approaches. When we think about historical trauma-informed care, we're actually, again, also integrating in these histories of populations. And a reminder, historical trauma is not unique just to American Indian populations, though it's most often associated with that. We can think about populations across the board that have dealt with histories of trauma and, again, racism, discrimination, and targeted abuses. But cultural safety really serves as that underpinning for all of these. It's looking at this not only in that one-to-one relationship, but examining our systems overall and confronting any institutional betrayals and systems of care. How are we creating systems that do not exert structural violence against populations that we're working with? And this is what we're seeking to put out there in the world, is examining our systems within this framework. Now, cultural safety, again, is not a new concept. Again, it was developed in the 80s and moved on into many different countries, including, of course, New Zealand, Australia, Canada, and the UK. And there's lots of research in all of these different avenues and countries around cultural safety and practice, but it is new within the US. It's barely getting traction and recognition. But they write again that, again, cultural safety is a function of cannot be evaluated as a function of knowledge of the practitioner. It's an outcome in and of itself that the practitioner can only help facilitate. So this is, again, that work in progress in relationship, not only with the patient or our clients, but with the population and with our systems as a whole. And so facilitating cultural safety is multi-layered, multifaceted, but in part, what we're asking is to see the person not only as an individual and a family member within a family system and a community member within a community system, but our own relative, because we're part of that same system. And how do we relate to that person and understand everything that comes with them during that time frame? It's facilitating trust, facilitating access, facilitating cultural practices, all of those areas, again, in bringing that forward. And again, the patient defining what feels like safe care. Next slide. We also think about assessments. And again, in this particular case that we're talking about with maternal mortality and morbidity, assessments should, of course, be looking at the basics: women's age, planning and acceptance of this pregnancy, perceived health during pregnancy, culture and cultural practices, values and norms, beliefs. But we should be also examining positions, social networks, accessibility to service providers, accessibility to those social determinants of health. What's going on in the environment for that client? What's happening in that space? What, again, access do they have to the needs that they have to, again, promote a healthy pregnancy? What expertise may they have, even within their own cultural community? And how do we provide treatment and communication that's free of bias or direct or indirect discrimination is really key, again, in delivering cultural safety in practice. In our next few slides here, we actually talk about turning to our relatives, in part because those countries that have adopted cultural safety as the basis for their healthcare systems have been studying this work of cultural safety in practice for some time. This study that we reference here, we won't read through each and every piece, in Toronto talks about how they examine cultural safety and its benefit not only to Indigenous patients, but to other patients as well. And this is what's also really interesting. When we think about Indigenous concepts, Indigenous constructs, Indigenous worldview, they're not only beneficial to Indigenous populations, but they benefit populations across the board, in part because of the way we view the world, the way we think about systems overall, the way we think about connection overall. And so they write about relationships and communication as very key in their projects and working with women who were coming into their facility for maternal care, and how there was respect for patient choice. Those relationships were really key in that cultural safety, and feeling that in a space where cultural safety was prioritized, it was very different from past experiences in dealing with other providers who were not working from that framework. Next slide. They also talked about sharing knowledge and practice and creating culturally safe spaces so we can bring our identities in, bring our realities into that treatment space, that service space along with us as clients, as patients, and also have that reflected back to us in the service. And so that's our goal in some ways, to create systems of care that we can do that, especially here at UNM. We serve a large Native American population here at the University of New Mexico. And in New Mexico, American Indians make up 12% of the state population overall. So we really should be examining this idea of cultural safety and how we examine our systems of care. Next slide. So we want you to challenge you to think about, how do you build cultural safety into your everyday practice? And in our particular presentation here, we're talking about women's health and specialty care settings. And what are your roles? Advocate, healthcare worker, providers and staff, educators, learners, researchers. All of those components and roles that we serve can play a role in promoting cultural safety in women's health. Next slide.
I'm gonna jump in, Jen.
Go ahead.
Cool. So, and I just put in the chat, I think these roles definitely relate to the work that we're all doing as well. And so if you have some additional ideas in each of these roles that we haven't mentioned, please feel free to throw it in the chat and share that. So in your role as advocate for patients, communities, health systems, really examining that role in terms of those social, racial, economic, environmental, health access, and justice frameworks. How might you within those roles utilize cultural safety, for example, and your newfound understanding today of that, or the increase in your understanding of it if you were already familiar. We also suggest some things in here that may not be for any given one of you, but it might be for some of you, or it might be for some other people that you interact with on a professional basis. Meeting, for example, with local tribal, state, and national representatives to understand health needs, infrastructure, support needs, and impact on healthcare. Advocating for policies that shift power differentials in patient care. Things like shared decision-making and how to create culturally safe, informed consent. Support full funding for the Indian Health Service and expansion of mental health prevention and treatment, funding to tribes and American Indian Alaska Native Services. If you're not aware, Jennifer and Teresa here are experts on American Indian healthcare in the state of New Mexico and the roles and responsibilities of UNM in that system. So if you ever have questions about them, I'm going to say reach out to them, and if they can't answer, I'm sure they know the right person for you. And then also, of course, to look at our roles as healthcare workers with patients and clients, of course, but also within our teams and the larger system. And I think really importantly, you know, before we put this presentation together, we met as a group, the four of us, and talked about our own experiences as moms and with the healthcare system. And I think a big piece that came out of that for me was really we wanted to emphasize the need to not make assumptions about patients when they walk through the door, to really allow a lot of space for learning about them in a curious way, collaborating to identify needs and strengths, connecting with services that can help address social determinants of health and barriers to care or access to care, deliver quality, safe care, communicate well and be caring, provide choices, facilitate access to interpreters and choice of gender care provider when needed, consider cultural practices as a strength and encourage patients to connect with those where they can, develop composure, managing verbal and nonverbal expressions of disgust and surprise. This is one of the pieces I think of cultural humility that that's hard to teach. But I would encourage all of the folks in teaching roles here to really think about how might you provide feedback around those pieces when you're observing patient care. Paradoxical combination of two ideas, right? You want to be informed and not all knowing at the same time, right? You are an expert, but you're not the only expert in the room, and you're not the expert on the individual in front of you. Within our teams and systems, working to remove barriers to continuity of care, creating physical and psychologically safe spaces, learning about and using trauma-informed care principles and language at every level, utilizing culturally safe and relevant ways of eliciting feedback from patients and the populations you serve, and utilizing quality improvement processes to address local disparities, being really reflective about how things are going within your spheres of influence. Keep going. And then finally, we kind of we have this and one more, educators and learners. You know, I mentioned teaching a minute ago, but really facilitating and modeling reflective practice. I know within our psychology program, we put a lot of emphasis on reflective local practice. If that's a new idea to you, reach out, we can point you to some great resources. But really, it's that idea of knowing yourself in a way that is reflective and allows you to be curious about others without making those assumptions. Providing opportunity for feedback from patients, building shared decision-making skills for yourself, and also encouraging your patients to build those skills as well to be effective, and include structural factors and historical context when discussing individual risk factors. Think about the broader picture for that patient and what else they might be facing when conceptualizing a case, for example, or reviewing steps that have been taken. And then thank you all for being at Grand Rounds on a Friday. And engaging in your responsibility for lifelong learning. I really hope that you are taking action and specific steps to learn about the populations that we serve here in New Mexico, and seek consultation from many of the experts here who presented and in our department and elsewhere in the HSC and UNM. And we want to really emphasize the idea of reflexivity here. Am I talking through treatment needs and approaches for my patient with my peers regularly, including challenges I'm experiencing in rapport and examining any biases that come up in those relationships and discomfort? So the idea that it's okay to be vulnerable about what you do and don't know, and that actually it is, you know, the mark of a high level professionalism and skill level and competency level to seek that type of consultation from each other on a regular basis. And finally, if you wear a research hat or you mentor research or you consume and are a critical consumer of research, I want you to ask if you are the researcher, ask important questions, but listen for important answers. Sometimes we get caught up in what's fundable or what we want to know, but really what we should be always asking and then listening for the answer that the people we want information about, what they are saying about themselves and the process. So listen for those answers, even if you didn't want to hear them in the first place. Seek out opportunity to learn about health equity and how it relates to your area of research. Include structural factors and historical context, not just individual risk factors. Evaluate and consider your protocols, recruitment, how you advertise your research, who's centered in your research, who are you really speaking to, and learn more about methods and approaches that facilitate richer collaboration, things like ethnography or autoethnography even. And mixed other mixed methods and qualitative methods. Oh, I lied, we had one more. And if we haven't quite hit on it fully, there are a lot of things that at the institutional level that can be done to support cultural safety. And of course, none of these lists are exhaustive, right? We could probably have brainstormed 10 more for each of them. But at the institutional level, cultural safety can really be nurtured by supporting and sustaining the implementation of trauma-informed care principles and language at every level, developing, improving, and maintaining strong relationships with those tribal communities, their governments, and their healthcare systems, ensuring regular inclusion and engagement of the population served, again, getting their feedback in an honest and open way, and advocating for policy changes that really take into account the access to care, community partnerships, and innovative practices, not just what we've always done, and a genuine desire to create systems that fit the population served, like Jennifer said earlier, rather than trying to fit the population served into the system that exists. Okay. I think Jen and Deidre and Teresa, I think we have a little bit of time we could ask these questions real quick and then finish up and have our Q&A. So we'd like you to recall the case illustration we provided at the beginning. And if you could answer in the chat, or if you'd like to unmute briefly, you know, what would make the experience more culturally safe for that patient? What would you like to see the provider or past providers or teams do differently? What would you want them to know? Or perhaps maybe in your role in behavioral health, if this patient later came to you, what would you want them to know? And I'll give a few minutes. I'm going to count to 60 in my head really slowly for the chat. And then we'll wrap up and we'll have some time for Q&A. Thanks, Dr. Khalil. Ideally, no patient blaming. Oh, and Dr. Rose is there with you. The name. I'll add a little bit of information. One of the cases that formed this composite case was a patient actually seen through perinatal mental health who had nearly died from postpartum preeclampsia symptoms, high blood pressure symptoms, after needing to deliver her child unexpectedly without family support in Albuquerque with a NICU stay to follow. And she felt that she had been not well enough informed about the risks to her own safety because she was from a tribal community in New Mexico. And that really impacted then how she came to be referred to behavioral health, right, with severe depression. And all of those things played a role in that case conceptualization and what ended up helping her.
And we can add to that too as well, that distance potential, again, rural nature of our communities, access to emergency care, not always being in our local community, that can exacerbate that immediately.
Thanks, Dr. Bonham. Exploring how we can include more health information or education as part of healthcare and more professional healthcare providers from the same populations being served. Thank you. Okay, I'm going to move our slide along, but if you are in the middle of a thought or have some brewing, feel free to continue adding to the chat.
So we want to come back to this here for a moment. I think everyone is familiar with ACEs, and this is a wonderful example developed by Dr. Megan Rides at the door from, is it the University of Montana? Yes. She's a wonderful Indigenous researcher and academic who developed this, and it's really the basis too for the work that we've been doing along with this idea of cultural safety and of course historical trauma and healing from historical trauma. What we can examine as Indigenous communities, and really for communities overall, when we have that opportunity to have intergenerational healing, when we have our tribal sovereignty recognized, that ability to enter into cultural revitalization and traditional healing practices, then we have the potential to create thriving and safe communities, have positive childhood, family, and community experiences, have cultural identity development that again contributes to consistent corrective experiences. And our cultural values and coping skills are based in that knowledge, that grounding of our Indigenous identity. And that in turn, again, pushes us into this space of wellness and balance, supports us in those spaces of wellness and balance, and again, gives us that meaningful life and longevity. And more importantly, for our communities, cultural perpetuity and cultural safety. So again, we want to thank you for your time with us today in thinking about this concept. You're going to hear us, especially our team, bringing this more and more forward, in part because, again, it examines our systems. And what is based in Indigenous frameworks is beneficial for all. And so we want to emphasize that as part of our work and talk today. So thank you, everyone.
Can you go back, Jennifer? Just really quickly, we're all familiar with ACEs and how it focuses on an early death if you're exposed to multiple ACEs. What this really highlights is that we have had the knowledge and the practice and the cultural values that are really built to help us achieve a meaningful life of longevity. So many of our cultures and our traditions are based in those strength areas. Now, it's not always popular, and sometimes grants don't always give money for strength-based approaches. So we look at the deficits, and those are well documented. But what we hope you do is that you understand that you are part of that thriving and safe community. And as part, UNM, as part of the New Mexico community, we have not only a responsibility, but we play a large role in creating those pathways to meaningful lives of longevities, not just for our Indigenous relatives throughout the state, but for everyone throughout our community. And we hope you take that away from today's Grand Rounds. Thank you so much, everyone, for your time.
I see a few questions in the chat. Are these concepts being shared with IHS nationally and with these types of lectures? Jennifer, Teresa, Deidre?
I have shared them when I've done IHS webinars. Yes, so yes, it's a huge system to have an impact on, but yes, we do really work hard to ensure that we have these conversations in any of the spaces that we're so fortunate to occupy.
And I'll just add to that we are also working locally with the Indian Health Service, and even more locally with the local Albuquerque Indian Health Center to do regular training and consultation with them and their staff on this particular model. And so we've been invited back quarterly to touch base with their team, look at systems, look at their approaches, and really work to change some of their outcomes within their work.
Thank you for the comments in the chat. I'm going to read Dr. Kreischman's out loud. A brilliant presentation by the team that defines collaborative, mutually respectful care and patient advocacy. Thanks, Avi. It really was a great project building this. And at some point, my colleagues haven't heard this yet, but I'll probably be telling them we should write this up as a paper because I can't help myself. So, you guys ready? Any other questions? Oh, there's some.
And we do want to give, again, recognition to Teresa Gomez, who is joining us by phone. She is on travel, so unfortunately isn't chiming in, but helped us to develop the presentation that you see today and all of the work that went into it. Mm-hmm.
This question about how to, how best to offer this to particular sites.
Dr. Pence, do you mean in terms of training opportunities?
Yes.
Feel free to reach out to me, Dr. Pence, and then I can help with our team to coordinate.
Okay, that'd be great. I need to reach out to the new behavioral health director I work with down there and see what her thoughts would be. But I think it'd be awesome. Thank you.
Thank you.
We really appreciate just the understanding of cultural safety and how it builds on some of these models that are already there, and then how it may impact our work, especially in New Mexico, where we really do have a commitment to making sure that we provide the best care to the people that we serve. So thank you.
Avi has a question. Could you comment on how providing this to those we serve also prevents burnout for all of us?
That's a great question, Avi. I have to think about that. I really do believe that when we're shifting that power to our clients and looking at what creates culturally safe care, it takes a lot of that burden off of us of being the experts in the room. We're experts of our communities, of ourselves, of our bodies, and helping to share that may actually take some of that burden off of us as providers. So this is one of the ways I think that it may contribute to preventing burnout and keep us engaged, because we're in that lifelong learning. We're looking at how can we continue to spark that interest, spark that curiosity. And again, look at systems. When systems are supportive too, it takes a lot of that burden off of us as providers as well. Having systemic approaches that support the population that we serve, as well as the providers within the system, because cultural safety is for everybody, not just our patient population, but for us as providers too. That can also serve to prevent burnout. Any other thoughts from the team?
I think I'll just echo. I think for those of us who do psychotherapy, or those of you learning psychotherapy, I agree with Jennifer that we have expertise, but we're not the expert on the person in front of us in the room. And so to be able to really recognize the strengths and including history and culture and resources, you know, in the full picture of somebody, to really be able to then draw on those things with them as a collaborator, I think just releases the provider from a lot of unnecessary personal pressure, right? Which then can lead to burnout when things don't go how you planned. You know, sometimes it feels weird if for example, patient ends therapy early, and why did they do that? They need more. Well, maybe right now is not the best time for them, and you planted positive seeds in their experience with mental health, and they'll come back having had a good experience in the past, right? Just as an example, I think having that sort of broad valuing and view of cultural safety, I could see that decrease in the risk of burnout over time for all those reasons.
I just think it works really well, because when you work collaboratively, you're still getting the work done, but you're doing it with an incredible team. And sometimes the part of that team is our clients, our patients that we see. And when you have a team approach to a presentation, research, patient care, it really does, like Jennifer said, alleviate some of that burden, and multiple minds are better than one for processing things.
Thank you, everyone. Please reach out if you'd like the slides or additional resources. We're happy to share those. Hi, Teresa. Thanks for joining us from the airport.
Thank you, everyone.
Thank you, everyone.